to have the last talk of this session about the combination of TACE and ablation in patients with HCC.
Thank you again. We'll kind of talk about TACE and ablation, my disclosures again. So when you look on PubMed and see what's kind of been done on a topic over the last 25 years, you see there's been about 1,000 publications on this. So there's quite a lot of stuff out there. Just to kind of summarize a couple of these things, this is a meta-analysis about 1,800 patients that showed that overall survival and progression-free survival are improved when you combine TACE and ablation. This was confirmed in multiple aspects. This was a propensity matched analysis of patients comparing TACE and RFA with TACE, again demonstrating that you have overall survival benefit in BCLC-A and BCLC-B patients. Another propensity analysis, this study was between 2 and 7 centimeters on the HCC. This was between about 3 and 5 centimeters, and this actually compared TACE ablation and TACE plus ablation. And as you can see, overall survival and recurrence-free survival rates are both higher in the TACE ablation group than both. Additionally, there's been a lot of work done on TACE ablation versus ablation, and you see similar results. Just kind of 2 studies that kind of looked at it. So the question is why? And I think it comes down to the fact that imaging still doesn't see some of the more aggressive features of the cancers in about 25% of tumors less than 3 centimeters and 55% of tumors greater than 6 centimeters, you have presence of microvascular invasion. In addition, about a third of tumors less than 3 centimeters will have satellite lesions, as well as 72% of them will have satellite lesions over 8 centimeters. In some of the studies where they looked at explant data, they found that these satellites can be anywhere between 5 millimeters to a centimeter away from the index tumor. And so when you looked at groups that were looking at the margin on their ablation, you found that the bigger the margin, or the margin greater than 5 millimeters in the case of 3 centimeter tumors, or just the use of combination therapy, which in this case was elapiodol plus TACE, you can see that the survival improved during the follow-up period, as well as the tumor progression was significantly better. And so this Miyayama group out of Japan did an interesting aspect where they did a TACE, and they didn't just use elapiodol to fill the tumor. They did it to include some of the normal parenchyma, and compared it between different groups of DSA and cone beam. And how they split up the grades was the grade A was they got a nice margin around the tumor, as well as the tumor. There was tons of elapiodol deposition. In grade B, they were not able to complete the surrounding area with elapiodol, and in C, they couldn't even fill the entirety of the tumor with elapiodol. And you can see that their recurrence rates were pretty high. The disappointing aspect was that even in patients that had complete staining of the tumor as well as the local surrounding, they were still a 30% rate of recurrence. And so this paper from Ko, they looked at 64 patients with residual recurrent tumor that was less than 2 centimeters. They had treated 75 index lesions, and they looked at how they ablated after the TACE. And what they did was they looked at groups that had complete ablation of the staining, not just the tumor, and complete ablation of just the tumor and found that you had increased progression if you just ablated the tumor and not the stain around the tumor. And so I kind of look at this as when you're doing these, we probably need to increase the margin, and I think that's one of the ways that these new softwares that are all coming out about ablation confirmation will help, is that you'll be able to figure out if your margin is correct. And so in my practice, I try to get as big as possible, but at least 5 millimeters if the HCC is less than 2.5. And if a HCC is bigger than 2.5, then I try to go at least 1 centimeter. And so why do we care about that? Well, data after transplant has shown that complete pathologic necrosis improves survival after transplant. And this is a group out of the University of Chicago that looked at DEB TACE, not so much conventional TACE. I generally do conventional TACE, not DEB TACE, and found that the complete pathologic necrosis was pretty high when compared to just TACE alone. And another group did a TACE ablate and showed that 20 out of 26 HCCs had complete necrosis on explant. And when you look at some of the data that comes out of the Boston group, you can see that the complete pathologic necrosis rate with TACE, ablation, and tear, although this was all comers, not radiation segmentectomy, you can see that there's quite a bit lower than the combination. And so why do I think it's that way? I think it gives you, a nice target. I mean, that's your tumor. It's obviously there's a little recurrence after the initial one. So when you can do this, it's a pretty annoying ablation. But when you see it, you can kind of just go straight in, complete the ablation. 3 and 6 months later, no evidence of tumor. Another example, you can get selective, you can do a nice stain, you can stain the adjacent area that may account for the microvascular invasion, the satellite lesions. You do the pre-ablation CT, you see the nice stain, you do your ablation, make sure there's good margins, and then 9 months later you still have good results. Some people will say, well, you have to bring the patient back. You can always try to do single session. So this is kind of a big lesion. We did a TACE and then ablated. You can take interesting images under fluoroscopy, especially when you have a thiodol or Lipiodol in there. And this is the follow-up. This is the immediate follow-up, and then this is about 6 months later. And then this is just another case. This is a fairly good-sized lesion, and then if you can do a post-angiogram and see how your hyperemia looks. You can now embolize a little bit, and this is immediately post-procedure, and then 3 years later, there's no evidence of disease. So in conclusion, I think TACE ablate improves complete pathologic necrosis and outcomes not just for intermediate, but I think even small HCCs, as demonstrated by some of the studies. Thank you.
So thank you very much. I have a question to that topic, and the classical question is which TACE, how many TACE, and what is the time interval? You are talking about single session. Are you always performing single session, and with which TACE?
Yeah. I have switched to conventional TACE. I changed about 3 or 4 years ago. I don't remember what the impetus for me changing was, but I just felt like I got better results. And so I generally will do conventional TACE. I do doxorubicin and mitomycin. That's just the way the pharmacy compounds our chemo. I generally start out with a TACE because it's easier and faster to schedule. It's not a rate-limiting step. CT kind of limited resource even at our hospital. And so I generally can get patients in for a TACE much faster than I can for an ablation. So I'll start with that. and then do the ablation when I can. It seems to work out pretty well. Generally for single session, I tend to stay away from left hepatic lobe and dome just because it can be annoying to do in fluoroscopy. Because the lung can get in the way, it can be hard to see sometimes. We don't have the benefit of contrast enhanced ultrasound at our institution, so that's not something that I can really do to improve visualization. And so, segment 6, segment 5, peripheral things is pretty comfortable single session, even without, the CT angio suite that we just got. So that's going to change how we do that. But it's pretty straightforward with fluoroscopy and cone beam CT. I think you can get pretty decent images and get good margins.
Thank you very much.
If there is anyone who wants to ask? Okay.
Can I ask Professor Philippe, do you consider in irinotecan case, do you consider the vascularity of the METs? I mean, it is arterialized or not? And is this affect the outcome?
We are talking about colorectal metastasis. Yeah. There is different vascularization because there is three different types.
You consider it in the treatment? Is it arterialized or not?
No, it doesn't play any role. It is important. It is important to perform the treatment on the complete liver lobe and not selectively in the metastasis. The reason is very easy. Irinotecan is the drug that you inject, but irinotecan is not the active drug. The active drug is CPT11, and that will be transformed inside the healthy liver parenchyma into the active drug. The active component of the drug is CPT11. So I strongly recommend not to perform selectively, but to let the liver transform the irinotecan non-active into the active CPT11. And there is no difference if the colorectal liver metastasis is hypervascular or less hypervascular. They are all vascular. If you take a free early arterial phase, but treat the lobar completely.
If you have a lesion 5 centimeters or more, you prefer to perform irinotecan or TEER?
The question was if we have larger metastasis, larger than 5 centimeters, are we performing radioembolization or TACE? Larger than 5 centimeters, this real-world study, CIREL, shows that it is a negative prognostic factor. So we will discuss to perform radioembolization in that case because it is a negative prognostic factor. Some patients we have are after radioembolization, by the way. And I saw one example of a very large singular, very large colorectal metastasis, about 11 centimeters. We treat with irinotecan TACE, and we had 60-70 necrosis after one treatment. So I cannot give you a standardization. It's a case-by-case discussion.
Okay, for Professor Ahmed. Can I ask a question? In bilobar disease, as regard radiation segmentectomy, what's your protocol?
So it depends, of course, if we're talking about bilobar disease, but no portal vein invasion versus there is portal vein invasion or not, and the multiplicity of lesions. So sometimes when you have multiple lesions, you cannot really do radiation segmentectomy. But we're talking about single lesions. If we have a single lesion in both lobes, I would treat both in the same session.
You treat in the same session, not sequential in separate session?
Well, you can do really, it's the same principle that we took from radiotherapy actually. You can treat up to 60% of the liver parenchyma without any consequence on the patient. It's not going to push that patient to liver failure or so. So if the total size of the angiosome that you're going to ablate with Y90 in both lobes is less than 60%, then it's still safe.
Okay.
For the lesions with multiple arterial supply, as we understand that you make splitting of the dose, or you are preferring then embolizing one and infusing one. It's correct?
So for lesions that have more than one supply, whether dual or even more, I calculate if we're trying to treat this with radiation segmentectomy, we calculate the volume separately for each supply, because we do that with cone beam CT these days. In the past, if you don't have cone beam CT, then you probably will probably depend on the MAA study, the CT, to calculate the total dose, and then you can split it based on visualization of how much each artery is actually giving to the tumor. So let's say one artery is giving 75, seems to be giving 75%, so you can split the dose this way. But in today's world, in the modern world where we have cone beam CT that is very available almost in every place, we actually do a cone beam CT with injection in every artery that supplies this, and we take the volume of that angiosome, and then we calculate a dose that is personalized for that angiosome, and we do that for every artery. So we deliver dose that is different in each artery based on how much is. No, we don't. We just give radium. Yeah, we used to do that because we were, we used to do that historically in the past, I would say, by embolizing some artery in order to divert the blood flow to the other one. But, now it's proven that, it's better actually to treat each artery, separately. Any questions from the audience? We still have maybe 5 minutes. Yes? There's a mic over here if you don't mind. Thank you.
Presentations. Thanks all the presenters for great presentations. My question for all the presenter, we want to know how the high dose using of radioembolization in global recommendation, we usually see that the high dose more perfect for treatment the target tumor. So our experience in Russia, we don't have maximum limit for the dose for the liver. So it's regarding to the physician or the patient situation individually. Every patient have individualized planning and post treatment session. So how you think about treatment with high dose, low embolic effect, or than other low dose or high embolic effect?
So I guess just to understand the question, you are talking about HCC, right?
Yes, mostly or other liver tumor as cholangiocarcinoma or colorectal metastasis.
Each disease is different. So colorectal liver mets is different than HCC. You cannot apply the same principles. The presentation that I gave was only for HCC. It's not for other tumors. If you have a single lesion in the liver, you can apply a similar, like a single metastasis to the liver from colorectal cancer. If you want to treat this with an ablative dose of Y90, and you can separate a artery that goes to that segment that has the metastasis, you can do that. There's no doubt about this, because the alternative to this would be surgical resection, right? Exactly. Because it's a oligometastatic disease, only one or two, you can just take them out surgically, and alternatively, you can ablate them with high dose of Y90. But we have to understand that CRC is a systemic disease, so it's going to spread anyways. You'll have other lesions in the liver, and it usually, after you treat those two, you'll get so many more in both lobes. And now your options will be a little less, right? Because you already took out some segments of the liver, the volume is less, and so now you have to be careful about your dosing. I personally prefer to treat CRC as a systemic disease, so I know that even if there is only one tumor in the liver on the right side, for example, or two, I usually give a treatment for the right lobe because I know there's some other microscopic metastasis in that lobe that will show up later. So I treat them as a whole lobe. And I adjust the dose in such a way that I give enough treatment, by that I mean around 150 or more grays to the liver, with the liver parenchyma being 60 or less. So I don't damage the liver, the normal liver parenchyma. So I adjust the dose in such a way, but I do a lobar treatment.
So you're also with high dose treatment.
Well, that's not really the high dose that we talk about with HCC. With HCC, we give a dose that is more than 400.
Yeah.
And I sometimes go up to more than 1,000 for a lobe when I calculate that. Because, you know, sometimes there's different types of Y90, right? There's certix and there's thyrospheres. The spheres, which is the certix, you can adjust the dose. You can just pull from the vial whatever you need. But for the other one, it comes in set vials. So sometimes you have to choose the closest vial. But when you calculate the actual dose that went to that angiosome, it's actually more than 1,000. So, you know, is more better? Yes, theoretically, there's no harm to give more most of the time. But for CRC, it's a totally different disease. And we have to be careful about how we treat or how to differentiate between dosing CRC versus dosing HCC.
Thank you very much.
Any other questions from the audience? All right, with that, I'm going to thank all my colleagues here, Professor Pereira, Professor Mustafa, Professor Hetta, and thank you so